comes to mammograms, there's screening mammogram and there's diagnostic mammogram, and who can tell you the difference between them? Well, this technologist can, because she's been doing mammograms for 2 decades. Listen to how she explains what is going on when you have a diagnostic mammogram and why it's so important to have it done the way that it is. Patricia has worked for the Rose for many, many years. She is our lead technologist, and she is the one who always puts the women at ease when they're having one of the scariest tests around. Let's talk about your breast. A different kind of podcast presented to you by The Rose, a breast center of excellence and a Texas treasure. You're going to hear frank discussions about tough topics, and you're going to learn why knowing about your breast could save your life. So we are here today. I'm Dorothy Gibbons, CEO of The Rose and co-founder, and I'm with Patricia Stapleton, who is one of our ace technologists, but she's more than that. She's been a part of the Rose family since 2003, and she's our lead technologist. She is supervisor over all of the imaging people, and this means every ultrasound, every mammogram person, our people that take the patients back and forth, our interpreters. So Patricia has a pretty big job, takes care of about 22,000 women a year that we run here at this location. And so welcome.
Thank you for having me.
Sure. So Patricia, we're talking about the person behind the mammogram machine. And, I think when a woman goes to have a mammogram, she has anxiety no matter what.
Of course.
Now, you've been doing this not just since 2003. You came in with another 9 years experience.
Correct.
So mammography has been a part of your life for a very long time.
Yes, it has.
What made you go into it?
It was personal for me. I had a brother who was diagnosed with leukemia at 15, and one day he suggested that I do radiation therapy. Well, I got to thinking, I didn't want to do radiation therapy. You're with you see your patients day in, day out, and you get attached. And I didn't want that attachment. Went to x-ray school, did everything else, did my rotations, MRI, CT. My first job was as special procedures and cath lab technologist. Well, then my husband being in the military, we moved around every 4 years. Moved to Corpus, worked for a private imaging center, and one day he decided he was going to bring up an imaging breast center and was going to pay for the mammography registry. Took it, passed it, started training, and fell in love with helping other women. That's where I felt that I made a difference. I just fell into mammography and been doing it ever since. And from there on, I worked at cancer centers or a dedicated breast center.
So to be a mammography technologist, you have to have already gone through radiology technologist school, right? You have to have had that license.
Yes.
And then you have to do another.
Well, what I did is I trained on the job. And then I had my certification. So you do your 2 years of x-ray school or whatever x-ray program you decide to sign up for, and then you train on the job and get your certification.
So, and all of our mammography technologists are registered.
Yes,
right?
they're breast mammographers, and we also all our ultrasound technologists are registered as well. We have several mammographers who are also certified breast ultrasonographers.
So why is that important to be what we call multimodality, but it means that you can do more than one procedure?
Well, it helps you in the overall care of the patient, helps you understand what images and what studies are needed to get the area concerned or get the job done. And it's just more knowledge.
So I think it's so interesting that you said you didn't really want to be attached. We have patients who come in and go, Patricia's the only one who can do me. I mean, you know your patients. You talk to them. You become a part of their extended family. So, you know, I mean, there's a lot of difference in doing mammography.
Yes, there is. And I was just thinking about that this morning as I was walking about certain family that, you know, I become attached to, and we're friends outside of work as well. Or this is a month where patients come in and they request myself, and I have to make sure, the schedulers make sure that I'm going to be here. I put them on the schedule and make sure I wait. Even family members that I work with who I do their mammograms, and I do their mothers or their grandmothers who make sure that I'm here.
Well, you do have a reputation for being very gentle and taking your time, and I can speak to that personally because Patricia's been my mammographer for a very long time. And recently I had a magnification view, and I've had mammograms since I was 35. I've never found them painful, never had a problem with them. Of course, I've got very fatty replaced breast, but when I had to have that done, it hurt. It's the first time I've ever experienced any kind of pain with a mammogram. And I remember that, you know, I was concerned, and you explained it to me in a way I'd never heard before. So tell me what happens. This is a procedure you do when there's a suspicious area or calcifications or...
Yes. Whenever we do a spot magnification, and spot magnifications are basically done when we see microcalcifications. Microcalcifications are small specks that resemble salt. Depending on how they're shaped and formed, can determine the next course of action, meaning that these microcalcifications can only be seen on a mammogram. So you have to have your mammogram. They can't be felt, and it doesn't hurt. It's only detected by mammography. So the doctor reads your screening mammogram. You come back for additional imaging, which is a spot magnifications, which is specifically for microcalcifications. We turn an 8 by 10 into a 10 by 12, 11 by 14. It magnifies just the area concerned. Instead of focusing on the entire breast itself like we do with the regular mammogram, we're focusing on the little bitty area, maybe about the size of an orange, that we have a compression paddle, and we compress just in that area. So that's why it hurts. And if I'm compressing anywhere near the nipple, it's going to hurt even more. The nipple is one of the most sensitive areas of our breast.
Right.
And so that's what hurts. Compression separates your good tissues from your bad breast tissue. So you want to make sure that you have adequate, firm compression. Now, not super tight compression, but just enough where I'm not able to make an indentation with my finger when I touch your breast, kind of like a really nice blown up balloon. You want your finger to bounce off the breast.
Good tissue, bad tissue, that doesn't mean a whole lot to me as a layperson. Give me your other example that you used to tell me why it's so important to compress it.
Well, what happens is when I compress the breast, normal breast tissue, which just either fibrous tissue, which is a tissue that holds the breast together, or glandular breast tissue where all the ducts and everything's housed in, come together. Sometimes they overlap. So what you do, it's kind of like this. Okay, I hand you a ball of putty, Dorothy, a silly putty, and I put a little bitty rock in there and I say, here, find that rock for me. Well, how are you going to find it? You're going to have to tear the silly putty apart. Well, I can't do that with the breast, so smash the silly putty and get a nice firm compression, and voila, there's the area of concern that you're going to see. And again, when you're doing mammography, now that everything's digital is very unforgiving, kind of like whenever the newscaster's on TV and they got a big old spot on their dress, you're going to see it.
Right.
Same thing with mammography. You have to have firm tight compression to reduce the noise. And what I mean by noise is all the blurriness. And there's also certain criteria that we have to meet. And if we don't get adequate compression or meet certain criteria, it's going to get kicked back to us from the radiologist.
Right. And usually you can tell before the patient leaves. If you,
Absolutely.
Yes.
It's instant now. The image pops up on the screen.
And so when a woman hears that she has to come back for more films, that has nothing to do with the first group of films being bad or having a bad image or any of that. That has to do with finding that area. And I know one time you mentioned that about the plane and the clouds.
Yes, dense breast.
Yeah. So explain that part to me.
Dense breast is a type of breast tissue. It's nothing bad. You have fatty breasts where you can see right through a breast, which is fatty in the breast is the best thing to have because it's clear as day, like a nice clear blue sky. Now, dense breast tissue, if you look up at the sky, it's just like a big old puffy white cloud. Now, things hide behind that cloud, just like things like to hide behind a dense breast, a cyst, a very small, tiny cancer. So with dense breast, when you come in, that's how I explain what the tissue is. Dense breast is not anything bad. Mm-hmm. It's just a type of breast tissue.
But it can.
Yes, it can.
Extra worrisome, and many times we do other procedures.
Yes, we do. 3D is very good for dense breast. However, if something is ultrasound, an adjunct to mammography helps differentiate if we do see a lump on mammography or if we see nothing and you have a dense breast, the radiologist is still going to recommend you do an ultrasound because it's going to pick up that solid or that cyst that's behind that cloud or that little bird that's behind the cloud once you start separating it.
Yeah, that was the best analogy I ever heard.
It's a big old
plane
puffy
has gone behind the cloud, and how
it's
can
hidden.
you see it?
You can't see it.
Right. So, good.
But it's just a normal, dense tissue.
Younger women normally have this?
Yes.
And older women normally have the fatty replaced?
Yes.
But that doesn't mean everyone.
Correct.
Right.
And the older we get, we start losing that density in our breast tissue.
And the other thing of it, when a woman sees that on her report, if it says we want to do more studies, don't be real concerned, but make sure you do the studies.
Yes.
Okay.
It's a recommendation. I have dense breast, and I do an ultrasound every other year unless I feel something or my radiologists say, let's do an ultrasound just to be safe.
We do biopsies here.
Yes.
And in a bit, I want you to explain the difference between an ultrasound-guided biopsy and a stereotactic. Everybody kind of knows what ultrasound is. Some people know what stereo means, but they sound so intimidating,
Yes.
when it's about your breast. But how do you calm patients when she's having a biopsy? That's an invasive procedure any way you go.
Absolutely. Well, just did a stereo this morning, and a patient was extremely nervous. We bring them in, chat with them, explain the procedure from start to finish, and we walk them through the procedure and mix in a little bit of personal and the procedure as we're going along to try to take their mind off the procedure. But every inch of the way explaining what the next step is as well. And most patients, in just explaining the procedure in detail, calms them. Mm-hmm. Mm-hmm. And we have the doctor and the technologist running the equipment, and then we have a tech assistant who's on the other side of the patient talking to him and looking at the woman's facial expressions, because women are very strong and very stoic. So if a patient is hurting or they're about to pass out, they're not going to tell you. Mm-mm. So it's up to us to watch that lady and communicate that to the physician so we expedite, especially the stereotactic procedure. On the stereotactic, the difference between the ultrasound core biopsy is that the area concerned is better visualized mammographically. Mm-hmm. So our approach is going to be stereotactically. You're compressed just like a mammogram, except we have a little bitty compression paddle with a hole in the middle where we have a very low margin of error to position the area concerned. And we take 15-degree angles from right to left which tells us the exact location and depth of the area concerned. And again, that's usually calcifications and asymmetry that's only seen on one view, and it's not seen by ultrasound. It's more invasive. You're compressed. A little bit bigger guide that goes in to collect the sample of breast tissue. We schedule the procedure an hour. It takes us anywhere from 20 to 30 minutes from start to finish. And we rush our doctors rush us to hurry up and get the patient in and out. I mean,
because you don't want them to be in that compression that long.
I wouldn't want to be in that compression thinking and visualizing the guide going around the breast, collecting samples of tissue.
So I think that's real important. Whether it's an ultrasound or whether it's stereotactic, you're actually getting tissue.
Yes.
With the biopsy device. It's not fluids, it's not cells, it's an actual core biopsy.
Yes.
It's just a day-to-day term when you're in this field, but for a woman it sounds it sounds really scary.
It is. And we assure the patient this is the alternative to surgery. I know that when stereotactic first came out was back like in 1984. And I remember that because I was in x-ray school. And I had, not in 1984, and I had to do a research paper. And that was what I did my research on. Lo and behold, all these years later, this is what I'm doing. So it's wonderful. Back before they had any of this, you'd go straight to surgery. They'd cut you and take out the piece of tissue or maybe even a mastectomy.
Right. It would be a one-day surgery, in and out, but it was definitely, and cost-wise, it was awful
astronomical
for women, yes. And just to go in and get that core. And the results from that core biopsy are pretty darn good. I mean,
yes.
Yeah, they're very they're very correct.
Yes, they are.
Because you are getting multiple samples, and it is core.
And as we're collecting the samples, we're also viewing what we're collecting. So we know without a doubt, 100%, that we got the area of concern.
I can remember when we first got it. It made such a difference with women. But I do remember that you still encourage women to take some time off after the biopsy to, and even though it's that quick and that, it doesn't take much, but it's still, why do you do that? Because they could go back to work.
Well, they could go back to work, but Dorothy, we go through vessels, ducts, and glands in the breast. And we don't want you to be picking up anything heavy, not even a 4-pound bag of sugar. You start lifting, you're going to start bleeding, and then you're going to have a problem. Yeah. You're going to bruise. It's going to be very painful. You'll get a hematoma, which is like a little blister, like when you bang yourself with a hammer on your finger and you get that little blister. You don't want to get a quarter size hematoma in your breast because it's very painful, and it takes a few months for the body to reabsorb that blister. And it hurts.
Yeah.
So we want you to take it easy at least for 24 to 48 hours. And a lot of our patients, they have physical jobs. So we make sure that we stress and even give them doctor's notes to present to their employer to take at least 48 hours off. Even though we don't make an incision, it's just a little poke with the biopsy device. It's
it has.
We're right in the middle of your breast.
And besides, you've had a major change. You've undergone something you may never undergo again, or it may be the first time. Why not take some time for yourself? I mean, I think that's one of the best things we do at the Bros is encourage women not just to take care of themselves, but to give them that self-care time.
Having the procedure is a big stress, but just thinking about the what ifs is a big deal. And once the procedure ends and you come off of that high or that stress of that procedure, we have lots of patients who pass out just from the stress itself.
Yeah. Why do you think women put off that annual screening? Now we're going from biopsies to screening. Help me understand the real difference between those two.
Screening, because we women take care of everybody else first and we put ourselves last. or we make excuses such as I'm too busy, I don't have time. Kind of like when you're on an airplane and they give that little speech, if it's going to crash, make sure you put the oxygen on yourself. Well, what do most of us want to do first is put it on the person next to you or your child, then you can't take care of no one else. And we see that quite often, where the patient has gone over a year or 2 years, and they come in and all of a sudden there's something there in the breast because they missed a year.
Right. But it was going to be there anyway. We just didn't find it at that year that we might have. Yeah.
We didn't catch it maybe when it was smaller, and now it's bigger.
Right. So that's one of the other reasons why we really need to come in for our annual and take that time for ourselves.
Exactly. And I'm going to be honest. I've been known to be 6 months to 8 months from having a mammogram, and I'm right there.
Right.
And when I have it is when I get like my third Rose reminder letter or my third call that somebody's calling to remind me to have my mammogram, and I'm going, okay.
I think that's fine for us to admit that. I've been there too, because we don't ever want to shame a woman. There's never going to be a lecture from us about why didn't you come in. We understand. We're women. We've been there. We experience the same thing. So I think our listeners need to hear that. Don't keep putting it off, but please understand we're certainly not going to make you feel bad about it. We want to make sure we find that.
I always tell my patients, well, at least you're here today, and I'm glad to see you.
So tell me how difficult it is to do a mammogram on a man.
Not difficult at all. The most difficult part is trying to make them comfortable and not feel out of place, and making sure they understand that we're not skipping them and leaving them up front. We're waiting for the right room so we can bring them right straight into the room. And women aren't uncomfortable when men come to the back. It's the man that's uncomfortable coming to us. But it's the same as doing a small busted woman. No difference.
No difference.
No.
And you go through the same process of explaining what you're going to do and why you're doing it.
Yes, ma'am. We go through the same process. If they bring their wife with them, we also let the wife come in with them. It's much more relaxing for him, and the wife really gets a big kick out of it as well. So he can he can understand what women go through. It's kind of comical. We had a male gentleman this morning.
So we do see a lot of men.
We see quite a few men.
What would you say is the most difficult part of your job?
The most difficult part about my job is whenever you have to tell someone that they have breast cancer, or just by looking at the images that they have breast cancer. And again, most of these patients, you wind up knowing something about them because they share it with you in the exam room. They just went through a divorce. They have 3 small children, or they just lost a mom or a sister, and here they are with breast cancer. And knowing that this is going to be
more about them, yes.
Knowing more about them, and that they're about to embark on the biggest journey of their life.
You mentioned something earlier when we were just chit-chatting about the personality of a mammographer. So touch on that just a little bit. You're the one that said you are a little what?
ADD. We, mammographers, we're an acquired taste.
Oh, okay.
Okay. We are very ADD. We're constantly moving about and trying to do so many different things at taking care of the patient that's a hard question.
Well, and I know most women can multitask, but when I listen to how you describe your day, or when I go back to the tech area, I mean, there's like a dozen conversations going on. There's different patients. There's calling the doctor.
And most of us back in the area, I've been privileged to work with these ladies for many years, that we're a family. And that's exactly how we treat each other, as a family. And we know whenever we have to bark orders or request things from each other, and we get it done. Even though I'm the lead and imaging supervisor, if they need me, I jump. I know that they're not going to call me if they don't need me. Right. Walked in this morning, and one of the stereo techs goes, I need you in stereo, threw my stuff down, put my gloves on, my mask, my name tag, and ran in stereo and picked up like nothing. Mm-hmm. And they give me the same thing back. And that's what we give every patient and our doctors. Right. So with us, I know that I'm real pesky. And when I ask for something, I want it now. I'm very impatient. And I've had to learn to be patient. Right. And that I can't have an answer now. So you being the CEO, I know you've experienced that for me as well a couple of times. But for me, it's personal. It's all about the patient and taking care of the patient. I put myself in that patient's place, and I hate waiting. I hate waiting for results. And knowing what I do, I know that results shouldn't take 2 weeks. I know that most know now, and we push our doctors as well. Mm-hmm. We all have those patients that we need to give a little extra, and we do.
Now, at one time, you would call patients to schedule their biopsies.
Yes, we still do.
Okay. And there's just a different level of discussion when the technologist is calling the patient. Correct. It's not just to schedule it. It's to kind of start that calming procedure right then. Yeah.
And whoever calls is by that patient from start to finish to the post calls.
Earlier you said your brother had leukemia. Mm-hmm. You've had a family with lots of illnesses.
Yes.
Do you think that makes you more compassionate?
Absolutely, 100%. As you know, I just lost my baby sister, and 5 years ago, she was diagnosed with a rare cancer, glioblastoma of the spine, that left her she went from being a vibrant mother, sister, wife, counselor, social worker, doing volunteer work to a paraplegic, and then we just lost her in March. My entire life changed. The first 3 weeks of her life when she was at the hospital, I really got to see how we had to do better in caring for our patients and listening. Mm-hmm. And I also learned how to take care of the patient in a wheelchair. It made me more aware. It just made me see things so differently, made me more compassionate, more calming, more empathetic to every situation, personal and professional.
Do you ever find yourself just hating cancer?
Hating, yes, and not understanding why it happens. But
I know it's a real thing.
It's one of those things that I try not to ask why. It's just one of those things that I put back in a file and as I don't understand and just leave it there. Yeah. And try to make a difference rather than being depressed or dwelling on it. Try to make a difference in someone else.
You've seen patients who have not survived. You've had that in your own family. What do you do to take care of Patricia?
Well, that's hard. I have learned to say no. I've learned to take care of me. And I've also learned to let go of those who can't carry me while I'm here. If you can't be here for me the way I can be here for you, and I'm the one doing all the giving, then I probably don't need you in my life. I've learned to let go.
Yes.
Is what I'm trying to say. And that includes family, and it includes friends. So I have a very small group of friends who will drop what they're doing in a minute.
Right.
And, the majority of them are here at the Rose.
Ah, yes. When you talk about the Rose family, it's
the Rose. It's my Rose family, and all these challenges that I've gone through, I wouldn't have made it without the Rose family. Mm-hmm. So I do believe in my heart that being part of the Rose family was no accident. Mm. My husband got me this job, by the way.
He did?
Yes. We had just moved from Corpus Christi, and I was getting on his nerves because I always took 6 months off to volunteer at my son's school, being in the military. Well, he was a junior. He doesn't want me to volunteer. So he saw a job opening, set up an interview. I get a call from somebody named Amy, which was the director at the time.
Yes.
And, he goes, we called, you're going to go. So I came, a 4.5-hour interview, and she offered me the job on the spot.
Wow.
And I have to tell you this story. And the reason I say it's not an accident is I knew Dr. Malillo. I've had heard of her, And at the time, Ward Parsons was also our lead interpreting physician. I had heard him lecture before. Excellent lecturer. Dr. Dixie Malillo, I saw her give a seminar in San Antonio at Lackland Air Force Base somewhere. And I can remember telling my boss who was sitting next to me is, wow, wouldn't it be awesome to work for somebody like that and in an organization like that?
Wow.
I didn't realize it was her until after my interview, and I went home and I pulled out all my stuff, and I was like, oh my gosh.
We have a saying here, the rose picked you, and I've seen it over and over again. So would you encourage any young woman to go into this field?
Absolutely. It's very rewarding.
And it's good pay.
It is good pay. It's no call, and it's family oriented, I feel.
Right.
Family is very important to me. And not only this field, but try to find a place like the Rose that family is important. And they're going to be with you through the ups and downs in your life. I wouldn't have made it anywhere else if I wouldn't have been part of the Rose family.
I understand that. We've had lots and lots of times in our Rose family life and in our individual lives that, we turn to our colleagues for help. And that's really true in most women's lives. Work is 70% of your day. Right. And it better be good. It better be fulfilling, and it better be something that nourishes you and doesn't pull you down. So what, in that other 30% of your day, do you have any other passions?
I like to run. I like to shop. I like to read and spend time with my husband and my son.
Anything else you'd like to tell our listeners?
Take care of yourself. Make time for yourself. If it's even 5 minutes out of the day to sit and stare out a window.
Thank you for that, Patricia. You've given us a lot of insight on what happens when you're having a mammogram or a biopsy. And I think I can only echo what Patricia said. We want you to take care of yourself. And that's it for this day.
Thank you for joining us today on Let's Talk About Your Breasts. This podcast is produced by Speak Podcasting and brought to you by The Rose. Visit therose.org to learn more about our organization. Subscribe to our podcast, share episodes with friends, and join the conversation on social media using hashtag Let's Talk About Your Breasts. We welcome your feedback and suggestions. Consider supporting The Rose. Your gift can make the difference to a person in need. And remember, self-care is not selfish. It's essential.